Hi, everyone. Thank you for coming to today's webinar. My name is Huang. I am the co-chair of ACRM's Complementary Integrative Rehab Medicine Networking Group. I am an associate professor at Occupational Therapy Department at Georgia State University. And now the co-chair, Matt Erb, would introduce himself.
Yes, hello everyone. My name is Matt Erb, and I, as noted, am the co-chair with Dr. Wen on this group and these webinars. We have a growing archive of webinars that we're very honored to have a variety of speakers. We're really looking forward to today. Just a little bit about my background. I'm a physiotherapist. I'm an associate clinical director with the Center for Mind-Body Medicine out of Washington, D.C., but I also have a clinical practice and live and work in Tucson, Arizona. So thank you.
Our speaker today is going to be Dr. Huang, and the topic is the discussion of acupuncture. We will introduce her in a little bit, but first we have some housekeeping.
Yes, so before we get started with Dr. Huang's presentation, I want to advise that this meeting is being recorded. You likely received a notice of that. This is for our archives on ACRM's channel so that others can view this. We often have several hundred views of these after the fact. I'd like to ask all attendees to keep your mic muted and any alerts or sounds muted if possible. We do hope to have a few minutes at the end for discussion or questions if anyone has any, and those can be typed into the chat feature, and we'll address as many of those as we can. And just one additional tip, once Dr. Huang shares her slides, you can resize the portions of the slides versus the videos that are on with a little slider bar that can slide left or right, and that can give you a fuller view of the slide depending upon the device that you're on. So thank you.
So it's my pleasure to introduce our speaker. Dr. Huang is Associate Professor of Rehabilitation Medicine at Emory University School of Medicine. She received her medical degree in Shanghai, PhD in neuroscience psychology at Vanderbilt University. And her residency training is at UNC Chapel Hill. Besides being a board-certified psychiatrist, Dr. Huang is also certified in integrative holistic medicine. She is certified acupuncturist in Georgia. She is the founding physician of the first acupuncture clinic and the first integrative medicine clinic at Atlanta VA Medical Center. And she often acts as a consultant to regional medical center about acupuncture service. She is currently co-medical director of Emory Acupuncture Clinic. She served on the editorial board of the American Journal of PMR and act as a reviewer for multiple journals, including those published in Complementary Alternative Medicine Research. Her own research publication have been in acupuncture, tai chi, sleep, traumatic brain injury, and geriatric medicine. To commemorate her service, the Women Veterans for Social Justice award her with Lifetime Award for Research and Practice in Integrative Medicine in 2017. We look forward to your talk, Dr. Huang.
Thank you so much for the introduction, Huang, and also thank Matt and Dr. Wen for inviting me to this talk. So I'm going to share my screen and see if you can all see it. Let me know if you can see my screen.
Yes, it looks great. Thank you.
Thank you. I am a PMR doc with a passion for evidence-based integrated medicine, and acupuncture has been one of my research topics. And I'm glad to share with you some of the updates in the acupuncture research and what it means in clinical application. I have no conflict of interest to report. So today, because of the time limit, it's only a 45-minute session, I have to leave out some minor research areas for the sake of time. If you have deeper interests, feel free to contact me to discuss later. But today we're going to focus on some updated research and what it means for our clinical applications, and I'd like to identify some future directions we can take. So the current research trends are more and more people are undertaking sham-controlled clinical randomized clinical trials because in the past, most of the acupuncture research were just clinical, like a series studies, clinical trials with no control or with no sham control. So the current trend is go into the sham control randomized clinical trials. And these trials are going beyond pain research and going beyond traditional acupuncture needling. And we also see more and more of mechanistic research nowadays. I'm just kind of learning how to control this slide thing. Okay, so sham-controlled trials is at least single-blinded to the recipient, and but can be double-blinded if a provider or outcome assessor are different. And in those cases, you can achieve even the double-blinding effects. So when you conduct a blinded trial, of course, you know, when the provider or the assessor is blinded, you will have reduced likelihood of bias attribution of events to one treatment or another, and it will be more focused on objectivity. And if the recipient of the treatment gets blinded, it definitely will be a reduction or elimination of placebo effects, conditioning self-reported outcomes. So self-reported outcomes are mostly affected by placebo effects. Sham control trials have been used widely in pharmaceutical studies for a long period of time, but because acupuncture is a procedure, so it faces more difficulty of finding proper sham methods. And so one method is obviously was used quite a while ago, is sham points. So sham points meaning that in the study they use acupuncture points, the so-called acupuncture points, with certain distance from real acupuncture points, and also not included in traditional points list. Sometimes they use those sham points, even though that they are acupuncture points, but not commonly used for that particular condition. However, when the needle pricks open the skin, there's always a risk of eliciting physiological effects, even though that the points were sham. So the invention of sham needles changed the game completely. It was first reported by Streiberger and Klinghans in 1998, and both of them were anesthesiologists in Germany. So if you look at the graph, you can see on the right-hand side, that's a real needle. So when the real needle penetrates down into the skin, through the skin, into the subcutaneous region, you can see that the needle shaft gets shorter, right? Because it's a needle, and then the needle is this long. So when you insert the needle shaft gets shorter. So what they invented was to have a telescopic needle shaft. So if you look at the middle part of the graph, you can see that even though that the needle did not penetrate the skin, the shaft goes down. Okay, so it creates a visual illusion that the needle was inserted. And other people later on, of course, use the same technique and create the same kind of concept and created different kinds of sham needles. But the basics are the same. We use sham needle control in one of our studies. And to assess the validity of such sham control, we had all participants in the real and sham groups answer if they felt needle prick sensation. And interestingly, all of them actually said yes in all sessions. Majority of the participants were unable to guess correctly of the group assignment, although they became more accurate by the end of the study. Perceived group assignment was independent of actual real versus sham group. So the blinding was pretty good. And another interesting thing is that 34.5% of reported adverse reactions were coming from the sham group. So acupuncture now does have a very valid sham needle technique to be used in sham controlled clinical trials. Having said so, current published studies still vary widely in their sham methods, and which may contribute to the mixed results of sham controlled studies. So acupuncture clinical studies mainly started in the 1970s, and the majority of those are for pain. The last 10 years, there was a boost of these clinical trials, randomized clinical trials in acupuncture. When I went on to PubMed and limit my search criteria to last 10 years, POTAX, humans, adults, and clinical trials, and type in acupuncture and pain and randomized clinical trials, I got 549 entries. After reviewing all these entries, I came up with this list, and these are the conditions that multiple randomized clinical trials have shown effectiveness of acupuncture. Of course, by no means that this is the ultimate list, because it's still the research is still ongoing and all that. But here are the things that really can help us deciding whether or not to use acupuncture in the clinical setting. So here are low back pain, knee pain, migraine headaches, neck pain, shoulder pain, post-surgical postpartum pain, dysmenorrhea, pelvic pain syndrome, fibromyalgia, hemophilia-induced chronic joint pain, pain in cancer patients, carpal tunnel syndromes, symptomatic irreversible pulpitis. Pulpitis is just teeth pain, plantar fasciitis, here they use dry needling. Some people would say, well, isn't dry needling actually a recent invention by Western medicine? I have to tell you that acupuncture actually has the same exact technique, even though they did not name it as dry needling. So nowadays, actually, many acupuncture researchers change the terminology to dry needling to describe the same technique for better understanding of what they're doing. Chronic myofascial pain syndrome, trigeminal neuralgia, acute sore throat, especially those coming from the auricular origin, painful diabetic neuropathy, chronic Achilles tendinopathy pain. And these are the ones that have had mixed research results. And so the conclusion is not there yet. So those include exercise-related muscle pain, TMJ chemotherapy-induced painful neuropathy, labor pain, because it may be better combined with massage. And there's also a list of medical conditions that do not benefit from acupuncture. So like acute ankle sprain, that actually surprised me a little bit. IBS, lumbar spinal stenosis, severe osteoarthritis, breast cancer reconstructive, acupuncture actually added no more benefits than massage alone. Okay. So today we're going to, I'm going to tell you a little bit more about the clinical trials beyond pain. And these are some kind of new developments in the recent couple of decades. So one is insomnia. And insomnia, about 1/3 of general population reported insomnia at some point. So it's a big issue. And it's defined as sleep onset, sleep maintenance, and early awakening problems in the presence of adequate opportunity and circumstance for sleep. Due to very limited success with sleep hygiene education and practice, in fact, this is actually very important in managing insomnia, and it's a lifestyle medicine type of approach. Unfortunately, has very limited success rate. People use hypnotic medications, and those come with significant side effects. The one and probably only treatment modality that has been proven to be very effective is cognitive behavioral therapy. And not only is effective, it also provides long-term effects. However, the treatment is with high cost and low accessibility because the therapist needed extensive training. So the treatments of insomnia have been very challenging clinically. On the other hand, acupuncture has been used in China since antiquity for insomnia. So in 2009, we did a review study and see, how many acupuncture studies are out there. And we included 30 studies, but unfortunately, only 5 of those were clinical trials. The rest were basically like case series. So at that time, there were not many clinical trials available. But now in the past 10 years, more and more randomized clinical trials are coming out, showing acupuncture being effective in treating insomnia. Insomnia can be divided into 2 major categories, primary and secondary. Primary insomnia is insomnia that happens without underlying secondary medical conditions. And for secondary insomnia is the other one. And I selected two articles to represent the studies in these two categories. For the primary insomnia, this group in China did one study in 2017, or published their study in 2017 in Sleep Medicine. It's a very good journal. And they recruited subjects from age 18 to 65, and total of 72 were randomized and 10 dropped out. Those randomized were going into either real sham acupuncture group. The sham was done with no needle insertion. They used a tube, that's acupuncture needle tube, taped to create a sensation of needle insertion. And treatments were given 3 times a week for 4 weeks, and they did assessment every 2 weeks for 8 weeks. So that means that there were 4 weeks without treatment after the initial acupuncture therapy. So significant improvement in the insomnia severity index for actigraphy, reported sleep deficiency, sleep awakenings, and total sleep time in real acupuncture group as compared to sham group during treatment and follow-up. Both real and sham groups have significantly improved self-rated anxiety and depression scores compared to baseline, but significantly better in the real group during follow-up period. So the other study I chose, of course, to represent the acupuncture for secondary insomnia. Well, it's done by our group, but more importantly, because people with mild TBI, especially with PTSD, can suffer significant insomnia, and very, very hard to treat clinically. Hypnotic medications are almost no in this population due to significant cognitive side effects. So this is a very hard for insomnia group. So we wanted to see if acupuncture would do anything for them. The veterans were recruited from Atlanta VA Medical Center, age 24 to 55. And after run-in period with sleep hygiene education and practice for a month, only one actually improved and was discharged from the study. So you can know that how low success rate is for sleep hygiene. And after the run-in period, we randomized 60 veterans into real acupuncture and sham acupuncture with PTSD stratification. Only 5 dropped out during intervention. Treatments were given 2 times a week for 5 weeks, but many of them cannot finish due to various reasons, scheduling problems and all that sort of thing. And so at least 6 were required to be called as complete. Assessment was done at baseline, post-treatment, and 1-month follow-up. So we saw significantly improved PSQI in both groups compared to baseline, but more so in real group. Sleep deficiency by risk actigraphy is more significantly improved in real group. However, the effects were not sustained after cessation of treatment. So as compared to the previous study, there is a loss of acupuncture effects after stopping acupuncture. Different, from the previous one, which actually had sustained effects. So reasons could be multitude. One is less treatment sessions that we had, less density of treatments that we had, and more severe population. Unfortunately, we do not do every 2-week follow-up, so it's hard to know if the loss of the effects were immediate or over time. But more insomnia studies are coming out, ongoing, okay? Some trying to investigate acupuncture effects on autonomic function in relation to insomnia and its improvement. So stay tuned for these studies result in the future. So another area of acupuncture practice is in neuro rehab, especially in China and other Eastern countries, such as stroke, spinal cord injury, Bell's palsy, etc. Today I'm going to just focus on stroke. They engage acupuncture treatments right after incidents, and clinical reports indicate a very high success rate. However, we know that many stroke patients can recover on their own within first 3 to 4 months after the incidents due to recannulation of vessels, brain plasticity, and etc. So without sham-controlled clinical trials, it's very hard to conclude that acupuncture is effective. So I reviewed randomized clinical trials in the recent 10 years for this talk, and I found the results to be mixed for motor recovery. So several, here are some of the examples of positive clinical trials. And the one combined conventional rehabilitation with acupuncture and Chinese herbal medicine. It has better effects for subacute stroke than conventional rehabilitation alone. And they, in that study, actually, the stroke was average about 34 days out. The next one, they combined scalp acupuncture, and which is done on the scalp region, and cognitive training. And they show that the combination can efficiently enhance cognitive and motor functions in patients with stroke during recovery stage. They also was about 3 weeks out, which may be a more effective rehabilitation treatment after stroke than routine therapy and rehabilitation training alone. But the study also showing that about the same, time out from the stroke event, acupuncture was not as effective as physical therapy, or the combination is not superior. Okay, so the results are kind of mixed for motor recovery. Spasticity is another thing that we actually, kind of encounter in the clinical setting after stroke. So several studies using dry needling, here again, it's dry needling, as part of rehab program could improve spasticity. And another study using TransUnit acupuncture points and improve spasticity and motor function, but studies in chronic stroke patients. So these are about years afterwards. So the first pink one was 5 years out, and the Wing study actually, the time since stroke was average 53 months, minimum 10 months afterwards. So in these two studies, acupuncture showed no effect. So acupuncture has also been used to treat mental health problems, but not much of research study in this field until recently. So most prominently is for anxiety and depression. So in anxiety, various clinical trials, acupuncture has provided anxiety reduction in women undergoing IVF, methamphetamine withdrawal, pediatric dental anxiety, smoking cessation, the anxiety during cancer treatments, and preoperative anxiety. And in that study, actually, they could use less meat for sedation intraoperative. So that's very interesting. I actually sent that article to one of my anesthesiology colleagues, and she's very intrigued. So acupuncture has shown to be pretty helpful in a lot of in anxious states. But for general anxiety, oops, sorry, this room actually has this automatically on and off light control, so I have to wave my hand once in a while. For generalized anxiety, there are some studies showing that acupuncture and electroacupuncture can be effective on their own or as adjuncts to pharmacological therapy. And even study have shown that acupuncture combined with medications can significantly improve the state when compared to using just the medication. So their control was not sham. I believe that in these studies, they used pharmacological intervention as the control. So depression has less research evidence, but I found one that they used either manual acupuncture or electroacupuncture combined with SSRI and improved symptoms and quality of life for patients with moderate to severe depression. That kind of surprised me. Because clinically, I could see mild depression people do well with acupuncture, but severe depression kind of 50-50. So this is an interesting article. But the main limitation of this trial was not using a sham control, so placebo effect cannot be excluded. So while we can see that acupuncture being effective in many conditions in clinical practice and even by randomized clinical trials, one question people often ask is how acupuncture works. So the mechanistic research is coming out, or I should say more and more people are doing mechanistic research to understand the biological or behavioral process, the pathophysiologic condition of the disease and how that interacts with the treatment and the mechanism of action for this intervention, or namely in this situation is acupuncture. So Huang's group in China, Huang is a very famous scientist in China, and he started mechanistic research for electroacupuncture analgesia way back. I think it was like in 1960s, 70s and all that. And they had a very nice and clear demonstration that acupuncture produces endorphins that can be blocked by naloxone. So that was a very fine demonstration why acupuncture works for pain. And his team, again, later demonstrated that different electroacupuncture frequency produce different neuropeptides. And that was published, he actually published a almost like a review article in 2003, and I think it's worth reading if you're interested in this type of research. So low frequency electrostimulation at acupuncture points seems to significantly increase in the content of amphetamine-like immunoreactivity, and high frequency, on the other hand, produce higher or increased content of dynorphin-like immunoreactivity, and alternating both frequency produced both and enhanced pain reduction clinical. And these acupuncture analgesia effects were further confirmed when the anti-CIRM injected and the effects were blocked. So very nice studies. One criticism, of course, is that these studies were done in animal models. But I should say electroacupuncture-induced analgesia has been successfully applied in surgery and treatment of heroin addiction with electroacupuncture had very good or very considerable success. And we know that once in the brain, heroin is converted into morphine enzymes, and the morphine binds to opioid receptors in certain areas of the brain. So clinically, yes, we say that their theory is or what they found about opioid receptors and acupuncture is real. Harris in 2009 did a very interesting article using a non-invasive PET scan to investigate new opioid receptors in human brain. They randomized 20 fibromyalgia patients to traditional Chinese acupuncture versus sham acupuncture over the course of 4 weeks, 9 treatments total. The sham control was used. Basically using the non-acupuncture points and with no skin penetration. And the PET scans were done in the first treatment session and then repeated a month later following the 8th treatment. The traditional acupuncture evoked an increase in MOR, which is a new opioid receptor availability in expanded brain regions that process pain and sensory stimuli within 45 minutes. And again, in long term, while sham acupuncture, in fact, decreased MOR availability. But another intriguing result is that the reduction in clinical pain was similar between real and sham groups, indicating a possible different mechanism for sham acupuncture. Instead of saying that acupuncture doesn't work, it just means that they use different pathways, real versus sham. So nevertheless, all these studies clearly demonstrated the regulation of endorphin system by acupuncture. So that is one major branch of mechanistic study for acupuncture. Nowadays, with the availability of functional MRI or other MRI capability, brain imaging studies are more and more frequent. So here I include 2 studies from Harvard, and I think they're worth mentioning. One was done in chronic low back pain patients, and these patients in clinical research actually, the chronic low back pain has been linked to deficits in tactile acuity in S1. So in this study, they actually showed that after acupuncture treatments, the tactile acuity in S1 was improved, and such S1 neuroplasticity in chronic low back pain following acupuncture therapy was correlated to the improved clinical pain level. So they said that could represent early mechanistic change in somatosensory processing that's linked with acupuncture effects. The other one was done in carpal tunnel syndrome, and they showed that there's improvement in primary somatosensory cortex somatotrophy with acupuncture, and that predicts long-term clinical outcome for carpal tunnel syndrome. So these are also very interesting phenomena. But I have to mention another big topic in acupuncture research, that is expectancy interference. And I will say that expectancy interference probably occurs in all kinds of treatment modalities. However, this was never done in pharmacological studies, and most studies are in the acupuncture field. So there are probably like quite a few of those studies done before this study was published. I'm going to present this one as the most current, and it's a very well designed study. So they used subjects with mild to moderate severe osteoarthritis, knee osteoarthritis with pain. Into one of these three groups, boosted acupuncture, standard acupuncture, or treatment as needed, just like the waitlist group. They had session one is baseline assessment, session 2, an fMRI scan session that included the resting state functional MRI, followed by an expectancy manipulation in the boosted group and first acupuncture treatment for both acupuncture groups. So after that, the treatments were the acupuncture treatments or the sham acupuncture, or the, they're actually both real. I'm sorry, I have to say that both were real. The same type of acupuncture treatments were done twice a week for 2 weeks, and then one time a week for 2 weeks. And then they had a middle evaluation in degree, and then afterwards one time once a week for additional 4 weeks. Baseline thermal heat pain stimuli were calibrated individually and delivered to the medial side of the affected knee to produce 2 levels of pain, mild to moderate and strong. So during the first fMRI session, during the second session when fMRI was conducted, the thermal painful stimuli was applied. And at the beginning of the session, the subjects in the boosted expectancy group were given a script explanation saying that person's response to acupuncture can be positive or neutral. It didn't say it could be negative. And that this response tends to remain constant over time. And they were also told that previous studies have shown that if acupuncture relieves the pain induced by experimental heat, that would indicate that they were more likely to have good outcomes for their knee pain over the course of the treatment. And neither of these statements were true, okay? And so in addition to those false statements to boost up expectancy for acupuncture effects, they also lowered the thermal stimuli after acupuncture treatments in both groups, but told the boosted group that the stimuli was the same. So they would contribute the decrease of the thermal stimuli to the acupuncture treatment effect. After these expectancy manipulation to boost up expectations, they found significant difference in expectation scores in the boosted group as compared to the regular group. That difference actually carried over to the clinical outcome. So the boosted acupuncture group had more significantly decreased pain scores, and the regular acupuncture group, even though also improved, but did not differ from the treatment as usual group. Interesting thing is that after the debrief in the middle point, at the debrief, they actually told the people in the expectancy group that they lied to them about the thermal stimuli during the first session. They did not really change anything after this. So the conclusion they had is that lot of the acupuncture effects are related to expectancy interference. So I'm not sure I can completely agree with that statement, but obviously expectancy does play a very significant role. And to reduce or eliminate that kind of role is definitely to go to sham control clinical trials, as we said before. So placebo effects come from experiential, instructional, like the one that they did in expectancy manipulation, social, and definitely expectancy is one of these factors we cannot ignore. The only way to do a very robust clinical trial is try to eliminate or reduce that kind of factor across each group. So another thing I want to just briefly mention, of course, we can discuss later in more detail in private if your interest is the complexity of clinical trials. Is way beyond what can be easily controlled. So clinically, from current research evidence, we can appreciate some clinical practice application. So acupuncture can be used to treat various pain conditions with good outcome. Acupuncture is safe and can be used alone or in combination with other modalities in treating insomnia, spasticity after acute stroke, anxiety, and depression. But on the other hand, we always have to bear in mind that patient-provider rapport, positive expectation can provide additional benefits beyond the physiological benefits of acupuncture. And clinically, we can boost up those benefits by having good patient-provider rapport and provide a positive feedback. But there's a caution that I want to mention. So clinically, providing positive feedback rather than negative feedback is fine. However, giving wrong statements can be unethical and legally risky if out of research arena. Okay. And in certain clinical trials, when acupuncture effects are small, although statistically significant, adding these components may have been the reason for clinically observed larger effects. So to end, I would like to point out some some future directions for clinical and mechanistic research that I would like to see. One is clinically, because acupuncture is a holistic and individualized treatment clinically. So how can we actually do research in individuality, and that will actually bridge the research, the standardized research method with the individualized clinical practice in acupuncture. There is one study actually people in Taiwan have done in allergic rhinitis, and they showed that different gene types, pH positive versus pH negative, could have different response to acupuncture, which is an interesting phenomenon, and that could guide us also into other individuality research. Frequency of treatments and its economical effect. So this is one thing that I found always kind of puzzling to clinicians and researchers, because the currently used acupuncture frequency is just basically a convention from China. And they do daily acupuncture or 3 times a week of acupuncture, because acupuncture is very cheap, about a couple bucks each session. But here, one session costs $100 or more dollars. So economically, no one can afford, several thousands of dollars of treatment, right? So I did a case series and reported that in chronic pain patients, acupuncture, most people actually respond to acupuncture to have at least 2 to 4 weeks of effect. So how we study this frequency to further guide clinical practice would be an interesting thing. Combined therapies, a combination with physical therapy, exercise, other modalities. It would be interesting to see if they do better or not. Mechanistic research, of course, the 2 main things that I would like to see. One is that acupuncture has different modalities. Okay, so for instance, like people doing like acupuncture needling versus, for instance, moxibustion is a heating up of the acupuncture point. They could have a different or the same mechanism. It would be interesting to see, because clinically we use different modalities for different kinds of conditions. Another thing, of course, acupuncture points have been used specifically for certain conditions, certain points for certain conditions. Is it real? Is it specific? Is there any specific responses? Points? Or is that just, needling the body? Okay, any place will produce the same effect. So these are the future directions that I like to see. Okay. Thank you very much for your attendance and any questions.
Thank you, Dr. Huang, for your presentation.
Okay.
I have a question. Is there any studies out there about the effectiveness of acupuncture on balance in different neurological or musculoskeletal disorders?
A good question. Yeah. Unfortunately, acupuncture has not been able to show a lot of effects in those conditions, like the balance issues or other neurological conditions like multiple sclerosis and all that, and clinical. So there's not much of research in that arena either. So unfortunately, in those patients, we usually do use acupuncture for instance, like a pain management or other conditions, not the neurological condition or the balance.
Okay, thank you.
Okay.
In your experience, what is the dose they need to show the effect to reduce pain?
That's the question. Yes. So the frequency is one of the things that I would like to see, and the other one is the dose. How many sessions would be enough? Clinically, we usually recommend people to try 5 to 6 before they say yes, it's effective or no. Most people, if it's effective, they actually get improvement within a few sessions, like 2-3 sessions. Some people would have immediate response. But 5 or 6, if they still don't see anything, then we would say, okay, maybe acupuncture is not working for you or for this condition. Research-wise, we use at least 6 sessions, or most of the studies use at least 9 or 10 sessions.
Thank you.
So
I also have a question, and I know we're getting close on time, and the question is 2 parts. Having come from a background in yoga, where there's a whole healing system and there's different limbs, like there's asana and there's breathing and there's ethics and there's each of the different aspects of this, the whole healing system. I think that that's true with traditional Chinese medicine, that acupuncture is seen as part of other aspects of the traditional model. So what I'm wondering about is how we extract just one piece of that to study from the whole system, and also how these like ancient indigenous or wisdom-based healing traditions around the world might be harder to study out of their original cultural context, and or if there's more nonlinear aspects of health and healing. I notice a tendency for, like with energy or chi or biofield medicine, that it gets automatically poo-pooed as not being valid, but I don't know that we can study those types of concepts with the scientific model. So I wonder if you have any thoughts about that. I know there's a lot in my question.
Yes, very good question. Very, very good question, Matt. So yes, acupuncture has also been extracted to be a simple, standardized process for many reasons. Research according to pharmacological paradigm for one. It has some benefits. We have to admit, for instance, easier to understand, by the population and all that. And also to be able to train more people, just like Western medicine. Western medicine is just, very standardized, very population-based, okay? So on the other hand, this paradigm simplifies a complicated system, like you just pointed out, okay? Yes, you're absolutely right. It doesn't address the subtle differences in the clinical practice. So give you an example, okay? Acupuncture treatment or acupuncturists, sometimes they use different treatment modalities during one treatment session, right? So they could use needling, cupping, scraping, moxibustion, and all that sort of thing for one condition during one session, right? So if you don't understand the subtle difference, it could be a problem. So recently, I have a friend who suffered from shingles, and she has been following an acupuncturist for her other medical conditions that will require moxibustion, which is heating up the acupuncture points, and needling. So her acupuncture provider did not take into consideration the newly developed shingles, and so continued moxibustion caused significant worsening of her symptoms. It's a convergence of these two. I would use a term is like almost like emergent science with art. Understanding individuality within a population is probably true for all whole healing systems. I think in fact it should also be true in practicing conventional Western medicine, even though that it's not practiced in that way yet. The fortunate thing for acupuncture is, of course, acupuncture has gained more and more popularity since 1970s in the West. So it has been less challenge for acupuncture now, or less of cultural influence that we need to take consideration into. But still, it is reflected in acupuncture research, from patient recruitment to expectation to outcome and social context of a treatment always needs to be considered in studying healing tradition, especially like the ones that you said, qi and all these. Unless we will be able to invent equipment that will be able to capture these physiological, energy, then we really have to kind of consider all other, we cannot really kind of kind of basically prove them and saying that it's not existing. It's just like a light, right? I mean, electricity, before we have the light bulb, no one knew electricity existed. Everyone knew electricity existed, but they could not demonstrate, right? The same thing. We knew some energy is existing in our physiological bodies, but unless we have some kind of light bulb to show it, we cannot say they don't exist. I'm not sure if I answered your question, Renee. You had a very good question. So.
Thank you. Hey, Sean, should we wrap now?
Yeah. Thank you everybody for coming, and thank you, Dr. Huang, for your presentation. It was very insightful.
Thank you.
Yes, thank you, everyone. And this will be on the ACRM channel and the next couple of days, probably next week. So thank you for tuning in, and we look forward to our next session. Thank you, Dr. Huang.
Bye.
Thank you.